we're just going to show this movie, which kind of gave us the initial principles in terms of what is an EPA, and then what we're talking about is a concept theory. Goes back probably 20 years ago from Tanaka. 12 years ago. Anyway, so at least we know what we're talking about. We have the same definition when we start to think about one concept.
Postgraduate medical education prepares residents for the work that they will perform in practice. This training is aimed at what a newly qualified medical specialist should know and be able to do. In the training plan, all professional activities are elaborated as Entrustable Professional Activities, also called EPAs. This describes the knowledge, skills, attitude and behaviour that are important in the execution of the EPA, and which tools can be used to assess this. If the resident is able to perform the EPA at level 4, which means with distant supervision, a summative entrustment decision can be made. In this animation, we will explain how the summative entrustment decision-making works. Firstly, the resident discusses with the clinical educator the set of instruments that they will use for observation, assessment, and feedback. This gives the resident and the educator a clear impression of what the learning pathway will look like. The resident then gets to work and collects feedback and assessments. In order to demonstrate competence, the resident submits proof of achievements to the Clinical Competency Committee. The committee or team will then meet to discuss the progress. Each of the members has observed the resident from various perspectives. They include the day-to-day experience with the resident in the clinical workplace and the accompanying gut feeling. Based on the confidence that they have in the resident, the Clinical Competence Committee decides how much supervision is required. We call this the level of supervision. From observation to performing tasks independently with direct or indirect supervision, to supervision at a distance, and providing supervision themselves. The resident receives feedback from the clinician educator. The entrustment decisions are documented and motivated in a portfolio. As the competence of the resident increases, so the educator's trust in the resident increases and the need for supervision decreases. This results in the resident completing an increasing number of tasks independently. Once the resident has demonstrated the required competence to work under distant supervision and has gained the trust of the Clinical Competency Committee, then they will decide together to take a summative entrustment decision. Having earned the summative entrustment decision, the resident has all the competencies required to perform this professional activity independently. Once the resident has received summative entrustment decisions for all EPAs and has passed all the training segments, he is allowed to call himself a medical specialist. A good approach to summative entrustment decisions making stimulates residents to increase their level of independence, backed by the trust of the committee and team.
So, that's the background, that's what we're talking about. And while the video was running, I handed out some paper for the next activity. So the idea is that we go through a kind of a rapid process in developing an EPA. So what we're going to do is I give you 1 minute on your own to come up with an idea of an EPA. Think of an activity in your specialty you're in that could actually be an EPA. So just on your own for 1 minute, and then discuss it with a partner on your table for another 2 minutes, and then come up with at least one good EPA per table. So the goal is that each table develops more than one EPA, but at least one EPA per table that you come up with in the next 8 minutes. I will have the criteria, like the conditions for EPAs are on this worksheet, and I will put them on the big screen as well. So these, so the EPA you come up with should meet those criteria. These are developed by or described by Ole and his colleagues, and it's important that we try to find activities in our everyday life that meets those conditions. So I will just start my timer in a second, and I will want you to, for 1 minute, think for your own, and once I'm give the signal, you discuss it with a partner, and then after another 2 minutes, you discuss it on your table, and you might come up with an EPA for your table.
So this really sort of, these criteria really get at the core of potentially what is lacking in the milestones. Because the milestones did not necessarily require formulation of lists of things that were professional activities that could be fully encompassed of, this is something, an activity or a task that I would entrust someone to do independently. Some of the milestones are a little bit more abstract, they're just general behaviors, professionalism aspects, whereas an EPA should encompass professionalism, medical knowledge, skills, all of the things that go into a specific interaction. An example might be, you know, for, I think the emergency room is something where it's really easy for us all to wrap our minds around. For example, you know, adequately working up a patient who presents with acute abdominal pain. It's not just the physical exam, it's not just the professional behaviors, it's not just the knowledge, it's how much supervision do I need to provide to a provider who's going to see that patient for the first time in the emergency room. So it really, it may involve multiple milestones, more than one. And we'll get to that later on in the discussion of how to map milestones to EPAs. But EPAs are really a full clinical activity that you might expect someone in your profession to be able to do with varying levels of supervision.
The fancy word is holistic. So we watch through a holistic view and not separate it in different competencies and really have the big picture of one activity. So I'll start my timer to 1 minute, and I will let you know as soon as we're done. So on your own, create your EPA, your activity and your specialty. And I know your table has a bit of a hard time here right now, maybe. But
I've got a laundry list already.
You can
Yeah.
So whatever activity in your specialty is something that makes your specialty your profession unique. It should be considered as an entrustable.
Well, I was thinking to look at the accreditation. Start from there.
That sound like a perfect plan. Initially, I
Each specialty is different.
Be able to carry
Pharmacy just came up with some, so that's why we were here to try to figure out.
So I already see that you moved to phase 2. You've been discussing. If you haven't started discussing, please do now. It's okay.
And another one I was talking about for the trainees to be able to
doing stuff like
medication work up and manage
medication adherence.
patients for 3 months old. I think
How you actually
To me, the
film was actually really good. I had never seen anything like that.
Separate entities regarding fever. What do you think?
So and this gets at the tricky part of EPAs is that eventually EPA. You don't want it to be a 200-page document. You can do that. What are the and maybe something as broad as taking history and physics is something that you would expect to see an EPA graduating medical student showing up as an intern versus how do you expand on that to specify managing data emergency. We don't need to. That's the challenge with EPAs is coming up with the specific things that are really the core.
It's observable somehow.
You guys are on the right track. I don't need to worry about the scope per se.
Give that
It needs to be a specific
or even just
scenario.
Look over their shoulder, watch them, tell the patient, here, all of this. I mean, the first
That's a great example.
Part A, Part B, Part C to know, like, okay, what does that manage? What are all the costs that? How do I do it? Like,
Then you get into that, which is the detail.
our lack of coverage is not because I feel so poor, but other
We might discuss that because this is where it gets really tricky, and this is actually where I think milestones. Because I think what's great is because it's
talking about
because
then
it's
you're not
so
talking about
that nobody ever has.
with respiration. No, just which is why they say it's just harder because it's a fever.
Let them know that they can discuss it.
Although I would actually be
Some of these things are being assessed in other arenas.
General discussion is allowed, so you're already doing it. And perfect.
There are other arenas of investigation as well. Where you're
Just come up with. If you have more than one,
I think specifically every time I do it, because I think all of the school the way forward is that's why is that was actually really exciting. I never thought of it that well, I guess all in all, I think that's like you said. It's a chip shop.
The next exercise would be matching and then you have a discussion about it because it's with some milestones it's easy. Some milestones are almost others for
This is like the checklist, right?
This is to define the EPA, and if you come up with activities, then you might find that some resemble the milestones, but others are not. So we will try to figure it out.
So
yes, we'll clarify. Yeah, so that's the definitions of the usage of the trust is one of the
You may want to correct that.
And then for residents, the ones they
my view is they don't work the way they work intended. So I always like to say the only ones who really like milestones are programmers and the other ones, I don't know, somehow they don't really work. And they're too detailed and especially the local ones, the selfie, whatever, assess and number of levels. This is where they don't work.
They rather they would assess EKG.
Almost not in family medicine. About 30.
Honestly, for properly reading EKG, maybe one of the aspects of clinical knowledge of, say, admitting a patient from the
Can we wrap up the discussion? Wrap up the discussions, please. We'd like to hear from the tables what you came up with. We just want to hear from each table your EPAs that you come up with.
Yours, I liked yours actually.
Yeah.
It's not.
Not clinical based, clinical based.
I like that. Yep, okay.
Yeah.
This table. What is your
We reached
EPA?
rapid consensus. You would imagine why.
So we talked about keeping a fairly broad EPA, so we chose to talk about every early doctor should be able to receive a newborn after it's come out and be able to take the newborn from,
the transitions.
Like, how do you call it? Like a primary assessment?
Not neonatal resuscitation, but yes, but basic. Like
Stabilizing
be able
newborn.
to assess the newborn, like Apgar score, and be able to see if it has the respiratory distress, and the basic newborn care that needs in the first couple of hours to be able to do that and supervise.
Perfect. Yes, perfect. It meets several of these criteria, so this would be a really good EPA.
And this is an important piece for my group because we were talking about how specific or broad to get. You could have different EPAs for interns, junior residents, and senior residents. That they could be. It doesn't have to be just EPAs for internal medicine residents as a whole. You could specify it by year, however you want to break it down.
So if you mention it, there is this concept of nested EPAs. So you start with smaller ones, like the core EPAs they use for undergraduate medical education, taking a blood pressure or doing a patient assessment. So these are really small EPAs, and then you can use and build on them and define them bigger on the long run. So what is your EPA that you come up with?
So be able to capably conduct end-of-life discussions with the patient.
Say it again, just to make sure, so that I understand it correctly.
Be able to capably conduct an end-of-life discussion with the patient.
What do you mean with capably?
Well, that's what's in the EPA, right? And that's part of the entrustable behaviors will determine whether they.
To me, it seems that this is already you have a quality in there, capably, but usually, and that's one thing to consider. Don't use any quality adjectives in the EPA, because the level of supervision will give your measurement, and not so like you just described. Like, don't if you describe it again without the.
It would be just be able to conduct the end-of-life discussion.
Exactly, and this will be the EPA, and then you choose the level of supervision somebody has on that one. Okay. don't use any quality. So that's a common problem with EPAs. They start already to use adjectives inside, so they and then it gets confusing. Okay, yeah, thank you. Now we're having an EPA here. Anesthesia.
We're going to pick a chip shot after that one. So just CVL line placement. So basically, it would consist of consent, indications why the patient needs it, risk, procedure, where site, where you're going to pick and why.
Yeah. So now maybe here's the discussion: what is just a simple skill, and what is an EPA? So and in the example of that you have is really everything. It's talking to the patient, have the knowledge of indications and contraindications, and actually perform the procedure. So it includes skills, knowledge, and attitude, everything in one. So we have 4 EPAs developed. The next thing is to try to map them, or the EPA that you come up with milestones. So this is where it gets tricky.
Oh, we missed this table.
This table?
Yeah.
I'm sorry, because I already. Sorry, come up. Yeah, I'm sure. I like that you spoke up.
Tell us next time.
Yeah.
So that's
gonna be tough to
is the other word. Okay, please tell us your
You will have an extra pen.
So we came up with a couple. One was manage post-surgical discharge of patients, and you had one on the pharmacy side, right?
Oh, collect a medication history.
Yeah. These are small activities that can be entrusted to a resident or in a certain level of supervision. Exactly. Perfect. So thank you for bringing it up. The next thing is that we try to make sense of milestones and EPAs and how they match. So one grid usually used, or Ole actually sometimes shows in his slides, is that one that we have the EPAs here. These are just sample EPAs, and then you have the core domains of the milestones mapped to this EPA. So some EPAs include all the core domains, and some don't.
But these are the ACGME competencies, not necessarily the milestones.
The milestones are,
It gets much more complicated. To do this truthfully, you'd need your specialties milestones
which
document.
I have here. This is pediatrics.
Sweet.
And it's only 30 pages, so easy. No, we don't have general surgery. You can use the general surgery one just to have a good sense.
Yes, we were talking about that at our table. The milestones were already mapped to the core competencies.
Right.
So now, because we don't want to, disqualify any of the work that's been done beforehand, the
We're
way
gonna make it
forward
more
for
complicated.
EPAs is we need to make it, unfortunately, probably more complicated and map everything that's been done before onto EPAs, and you end up with these very large matrices.
It just reinforces how interrelated they all are. They really
Correct.
are all part of the same thing.
Correct.
It's just a different lens and a different way of.
And it also highlights the fact, as we were saying before, that the idea with EPAs is that they're all-encompassing, that we should be evaluating residents not on these bits and pieces necessarily, but on these holistic activities that you're going to entrust them to go out in the community to do unsupervised. And it might have 7, 8, 9, 10, 11, 12 milestones are incorporated in that one activity. At the end of the day, you need to be able to do the actual activity properly. It doesn't necessarily matter if there's a 3 on the professionalism and a 4 on the medical knowledge. That's maybe too granular. And you really care about is, can I send this person out to see this patient alone, to do this after graduation safely? That's really the trust decision.
Yeah.